Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about a peculiar manifestation of COVID-19 that occurs only in children. It's called the Pediatric Inflammatory Multi-Organ Syndrome. Now, this isn't something that occurs with the acute infection. It occurs after the infection. It occurs several weeks to a month after infection occurred. And the infection oftentimes was totally asymptomatic. Now, we didn't recognize it in any of the reports coming from China originally. Wasn't diagnosed until mid-April in Italy and in the United Kingdom. Then it came to the United States in late April, early May, diagnosed in New York City and several of the surrounding states, then seemed to diffuse into the rest of the country, slowly going from east to west, already reached California. Have to realize that in this manifestation of the COVID-19, pneumonia is not a manifestation. Maybe there's some inflammation of the lungs, but it's not a pneumonia like we typically think of it as it occurs in adults. So why are some children susceptible and others aren't? Don't know the answer to that. Why did it occur just in Europe and not in Asia? The answer thought to be, well, maybe there was one form of the virus that started in China and when it reached Europe had some kind of mutation, and now that particular virus from Europe has come to the United States. That's why they didn't see it in China and they didn't see it originally in the West Coast. Well, children who are infected with COVID-19 tend not to have severe manifestations, and indeed, as a precursor to PIMS, or the Pediatric Inflammatory Multi-Organ Syndrome, they can have no symptoms whatsoever. They might have had symptoms of just a common cold, but nothing that was thought of as being anything important. The condition itself appears to be due to overactive inflammatory reactions. So the body's immune system has been stimulated, and it's the body's immune system that's causing the problem. It's not that the virus is attacking the body, it's that the immune system, your own immune system, is attacking the body. So it seems that it's a novel combination of a variety of different conditions. So it seems to be related somehow to Kawasaki disease, two forms, complete or incomplete form, toxic shock syndrome, although toxic shock tends to be an adult condition, but here it's not associated with the typical staph or strep that adult condition, adult toxic shock syndrome is. Sometimes we think of it just as cytokine storm. Cytokine storm is just what happens in some of the cancer patients who are treated with some of the fancier new kind of medicines, and it seems that it's due to the stimulation of the body's immune system. Well, that's the whole story. It's the body's immune system that's causing the problem. So how do we diagnose this condition? It's not on anything specific. It's just on a variety of manifestations that go together. So you can see the definition is a fever associated with inflammation that we diagnose with high neutrophil count, that's a type of white blood cell, low lymphocyte count, that's another type of white blood cell, inflammatory markers in a routine blood test, like C-reactive protein, and evidence of at least one system in the body that isn't working correctly. So it could be the heart, could have cardiac collapse, severe hypotension, low blood pressure. We could have problem with the heart function. The heart can't pump the blood. Maybe we have some problems in the respiratory tract and develop respiratory failure, but not because of pneumonia. Develop some gastrointestinal problems. We can have some abdominal pain and distension and vomiting. Sometimes there's even COVID that lingers in the stool, because it can linger in the stool for 20 or 30 days after the acute infection. Sometimes there's evidence of kidney involvement or neurologic manifestations, change in consciousness. Sometimes children are just in shock. Sometimes there's even coagulation in the system. So right inside the blood vessels there can be coagulation. But on study, it's found that this PIMS, or the Pediatric Inflammatory Multi-Organ Syndrome, is not due to infection with the bacteria, not due to the standard toxic shock with either strep or staph. Certainly it's not because the heart has been infected with a virus. When we look at PIMS, about half of the cases are between the ages of 5 and 14. Tend to be more common in boys than in girls. Overwhelming majority tend to do well over a period of time. If there's severe manifestations, oftentimes treated in the pediatric intensive care unit, treated for shock, maintain the blood pressure with injected medicines. If there's a different organ system that isn't working properly, obviously that's supported, and sometimes treated with intravenous immune globulin or the corticosteroids or medicines to reduce those cytokines, those inflammatory substances in the body. And oftentimes we have to pay attention to the clotting system because there's clotting going on inside the vessels. Now, let's contrast that with the traditional toxic shock. Toxic shock associated with same sort of manifestations, a fever over 102, a rash that's diffuse and it's red, patches scattered about the body, or sometimes all of the skin turns red, tends to peel after a couple weeks. There's hypotension, very low level of blood pressure, and have to have involvement of at least 3 different organ systems. So it could be gastrointestinal system with vomiting and diarrhea at the outset, might have breakdown of some of the muscle cells. We can detect that with tenderness of the muscle, or on a blood test where we can show that there are some of the chemicals that leach into the bloodstream. Sometimes there's redness of the mucous membranes, either the vagina or the back of the throat or the eye. We find kidney damage, detect that by a simple blood test, or liver damage, again by a blood test. We find platelets associated with the clotting system are way down. Sometimes there's disorientation or changes in the consciousness, but there are no focal neurologic signs that you might find with stroke. And with toxic shock, cultures tend to be negative, blood, throat, and cerebrospinal fluid. And then we test for things like measles and other kind of viruses or bacteria, and they're all test negative. Well, to make the diagnosis of probable toxic shock, you have to have at least 5 of the 6 conditions I just mentioned. We call it confirmed if you have all 6 of them. Now, toxic shock is a relatively uncommon condition. Strep toxic shock occurs about 3 people in every 100,000 per year. Death rate's pretty high. It's about 50% in staph. It's probably about 2 people in every 400,000 have a death rate of about 5%. But the closest match to PIMS has been the Kawasaki disease. Kawasaki disease is a multisystem disorder that's associated with a vasculitis, inflammation of the blood vessels, that seems to be triggered most of the time by a viral infection that occurred prior to the time in a genetically susceptible individual. So most people who are infected with viruses aren't going to develop this. And the condition, the Kawasaki disease, is virtually unheard of in adults. It's just a childhood disease. So what are the manifestations? You can see that it's fever. Fever lasts at least 5 days without any other explanation. It's a high fever, a spiking fever to 102 to 104, hectic and intermittent, doesn't return to normal for a week to 4 weeks without any kind of treatment. If you give it long enough, it will come back to normal after that period of time. When the person's febrile, minimal response to the typical medicines that we use, either ibuprofen or acetaminophen, and they have at least 4 or 5 other manifestations. So the manifestations could be the white part of the eye becomes inflamed, marked redness. So this occurs several days after the fever begins. Occurs about 90% of people. It's on both sides of the eye. There's no pus and no exudate. Seems to spare the junction of the white part with the cornea. We call that the limbus. Seems to be associated with sensitivity to the light. And if we were to do a slit lamp examination, we find that there's inflammation inside the eye in about 2/3 of the individuals. Now, there's also manifestations in the mouth and the lips. The lips themselves can become cracked and red and peeling. The tongue can be enlarged and swollen. Looks sort of like a strawberry with enlarged papillae. No discrete lesions, so no blisters and no ulcers. If we look at the skin, well, beginning about 5 days after the onset of the fever, tends to begin around the groin, then spread to the trunk and then to the extremities. There are patches of redness. They're not specific. They're not itchy. They can look like measles, or they could look like scarlet fever, look like a drug eruption, look like a nonspecific viral infection. If we look at the hands and feet, where we find the palms and soles are going to oftentimes be bright red If we look at the back of the hands and feet, we find that there's going to be an edema that's brawny and indurated and not pitting. So you push your finger in it and you know it's swollen, but the finger doesn't sink into the skin. Sometimes it's painful for these children to walk. We find that they have swollen nodes. Now, not a whole lot of nodes, just one or several, and they tend to be located right about here. That's only present about half of the time. The nodes themselves are 1/2 to 3/4 of an inch in length. They're not red, they're not tender. And if we consider the condition, if we consider Kawasaki disease, it seems up until 2004 thought you had to manifest most of those conditions that I just mentioned, but then it was thought, you know, there are a lot of people who have the condition who seem not to fulfill all of the criteria. So it's what we call incomplete Kawasaki disease. So incomplete, more common in children less than 6 months of age or in adolescents. So we make the diagnosis now, even when people only have 2 or even 3 of the symptoms associated with the fever. So they don't have to have the eye abnormalities, don't even have to have the mouth abnormalities. And now we say that there's another kind of manifestation where we have atypical symptoms associated with arthritis or arthralgias, pains in the joint. Typically starts off in the small joints of the feet and then goes to the larger joints of the leg. Associated with pneumonitis, inflammation of the lungs, poor function of the lungs, gastrointestinal manifestations, abdominal pain or nausea or vomiting, diarrhea, sometimes even gallbladder problems. We find that on blood tests, about half of the people have evidence of inflammation of the liver or hepatitis, not due to a virus, not due to the hepatitis virus. We find pancreatitis, inflammation of the pancreas. We find inflammation of the meninges, so meningeal symptoms, meningitis, or sometimes there's cranial nerve abnormality that might look like Bell's palsy or sensorineural hearing loss, sometimes urethritis. Well, the most important component of the condition wasn't originally described when Dr. Kawasaki first wrote about the disease. So the most important component of Kawasaki's disease is vasculitis, inflammation of the vessels, tend to be the median-sized arteries. Now, there was no mention of this initially, but about 5% of children who have the condition are going to suffer cardiovascular collapse. They're going to have hypotension. They're going to require intensive care in the ICU, the pediatric ICU. They're going to have to receive infusions of medicine to keep the blood pressure up. Problems tend to be early on due to myocarditis, inflammation of the heart muscle itself. That's even before the coronary artery aneurysms form. It's early on due to inflammation and edema of the muscle cells, not necrosis. The muscle cells aren't dying. But that could lead sometimes to some arrhythmias. Now, the aneurysms are going to develop, the outpouchings of the vessels, in about 25% of the untreated children. That means, of course, that 75% of the children are not going to get this kind of complication. Well, when the dilations or the aneurysms form, for the most part, they're going to heal spontaneously. They're going to go away and they're not going to be a problem. But sometimes we can get large saccular aneurysms, sort of like a pea developing inside the aneurysm, where all the layers of the vessel are lost. Then they can get a clot and it gets some calcification after on, and you might even develop a problem with rupture. Sometimes it looks more like a sausage. We call it a fusiform aneurysm. In this case, the entire wall hasn't been destroyed, and as a result, can tend to heal over time. Well, we can say you could have a dilation if it's less than 1/10 of an inch, or a small, medium, or a large, or giant aneurysm if it happens to be larger. It's a giant aneurysm when it's more than about 1/3 of an inch in diameter. Now, most of the time, if it's less than 1/3 of an inch in diameter, these lesions are going to heal by themselves. They're going to heal with the proliferation of collagen tissue. Everything's going to get back to relatively normal. We don't think the vessels function normally, but they look normally. And the good news is that on 25-year follow-up, if the aneurysms have not developed and persisted, we know that because of echocardiograms, ultrasounds of the heart, well, we can say that the life expectancy is just as good as it would be if a person didn't have the condition. If there's going to be rupture of one of the aneurysms, it's going to tend to be within the first several weeks. The aneurysms occur in the major arteries. So when you talk about adults and you talk about, well, I know somebody who had a stent put in or somebody had coronary artery bypass surgery, we're talking about the same kind of vessels. Those major vessels of the heart, the left main coronary artery or the left anterior descending the right coronary artery and their branches. But it doesn't have to be the coronary arteries, could be vessels going to other areas of the body. So some of the abdominal symptoms might be because of the mesenteric vessels. Could be the vessels going to the arms or the legs. The likelihood of death is only elevated, apparently, in those individuals who develop the aneurysms. It seems that if you don't develop the aneurysms, chances are you're going to do well. The majority of deaths associated with the condition, and they're relatively few in number, they occur somewhere within the first 2 to 4 to 6 weeks after the onset of symptoms. Well, this is a time when we have the peak of the coronary vasculitis and the platelets aren't acting well and they're clotting inside the vessels. That's when we have the major problem. And by the way, it's not just the vessels themselves, the coronary arteries, but it also could be the sac around the heart, pericarditis, or the heart itself, the muscle cells. We call that myocarditis. Could be myocardial ischemia. The heart isn't getting enough oxygenated blood. Or a young child could develop a myocardial infarction, a heart attack, or develop arrhythmias. And sometimes the mitral valve doesn't function right. We get what's called mitral regurgitation. That tends to heal by itself. And then if we look at the children who require pediatric intensive care and require mechanical ventilation, for the overwhelming majority of children, it's because of the problem with the heart, not the problem with the lungs. Unfortunately, there's no simple blood test that tells us, yes, you have Kawasaki disease. But when a person might have it because of fever and the rash and all of the other kind of manifestations, we have to make sure it's not the measles or the echovirus, adenovirus, or the toxic shock or the drug reaction of some sort or other kind of vasculitis. How do we treat the condition? Well, it was recognized in 1984 that intravenous immune globulin, so immune globulin given intravenously, would make the children afebrile and make all the other symptoms go away very quickly, and even prevented the coronary artery aneurysms from forming, restored the function of the heart muscle very quickly. Now, it was originally given in 4 different doses, but then it was decided that if we use just one relatively large dose of intravenous immune globulin and inject it over a period of 10 to 12 hours, that would just make everything go away. Certainly, if started within 7 days after the onset of the fever, prevented more than 70% of the coronary artery aneurysms, prevented all of the giant aneurysms, and could even extend that out to treatment within the first 10 days after the onset. And for some people, if they still had fever and the elevated C-reactive protein, the inflammation going on in the system, well, could even be extended beyond 10 days when the treatment seemed to do very well. Well, unfortunately, about 10–15% of the people, either the fever persists or it returns after a couple days. Well, that suggests that we have ongoing vasculitis. There's obviously an increased risk for the coronary artery aneurysms in those individuals, so a second dose seems to be appropriate. And if the second dose doesn't work, then we have other kinds of medicines. We have the cortisone, the corticosteroids, and we have the medicines that we use to combat those cytokines. How does the IVIG work? Well, it's a general anti-inflammatory drug, so it decreases the cytokines. It augments the function of some of the body's immune system to quiet it down. It decreases the synthesis of antibodies, and it also neutralizes any toxin that happens to be floating around. Now, if the condition progresses on so that the child is already in shock, then the medicine doesn't seem to work as well, or maybe even work at all. So it's important to begin therapy as soon as possible. And not only do we begin the IVIG at the same time, children receive hefty doses of aspirin. at a dose considerably more than you would normally take. That's kept on for about 14 days. That gets the temperature back to normal and acts as an anti-inflammatory. And then after the 14 days, the aspirin is continued at a relatively lower dose, at a dose kind of similar to what an adult might take when you take the aspirin to prevent a heart attack. Well, children are kept on that dose of aspirin for somewhere between 6 and 8 weeks if there are no aneurysms. If there are aneurysms, kept on basically indefinitely. Now, sometimes the aneurysms might actually have to be treated surgically. Well, interestingly, the American Heart Association in 2017, they came out with the guidelines for how to deal with Kawasaki disease. And in that article from 2017, they quoted 2 other articles, one from 2008, one from 2011, and both of those articles mentioned novel RNA viruses that were unidentified that seemed to have entered through the upper respiratory tract. And they found some of the particles of the virus still lingering inside the cell, in the lungs, and in other tissue throughout the body. Well, Kawasaki disease itself was described in the early 1960s, written first time in 1967 by Tomoyasu Kawasaki. And he wrote about this so-called mucocutaneous lymph node syndrome. He differentiated this fever and rash from other fevers and rashes caused by other kind of conditions. Now, he thought at the time that it was a benign self-limited condition, didn't recognize that it was associated with the coronary artery aneurysms or the vasculitis. But as a matter of fact, it's thought now that Kawasaki disease is the leading cause of acquired heart disease in developed countries. And it's the most common type of vasculitis in children. The overall mortality rate is only about 1%. So overwhelmingly, children who develop this condition seem to do very well. If they're not going to do very well, it tends to be relatively acutely, as I mentioned, between 2 and 6 weeks into the course of the condition. Overall, Kawasaki disease is diagnosed about 6,000 times a year in the United States in the pre-COVID days. Problem is differentiating it from other infectious conditions, because after all, it seems, at least when it begins, when a child comes out with a fever and a rash, you say, oh, has a virus infection. You don't initially think that it's Kawasaki disease may be associated with COVID-19 that the child might have asymptomatically had 2 to 4 weeks ago. Kawasaki tends to occur in children who are under 5 years of age. Only about 20% of them are over 5 years of age. Can be as young as 6 months or even younger. Tends to affect boys more than girls. Originally described in Asia, seems to be still more common in Asia. And it's important to realize that when we look overall at this condition, fortunately, the overwhelming majority of children are going to do well, and they're going to live a perfectly normal, happy life. So that's the story of COVID-19 and this PIMS, or the Pediatric Inflammatory Multi-Organ Syndrome. Seems that the condition, the viral infection, seems to stimulate the immune system. The virus might go away, but the immune system, at least as far as we know, seems to just continue to ramp up. And it's the overactive inflammatory reaction that seems to cause the problem. Now, is it Kawasaki disease? Is it toxic shock? Is it the cytokine storm? Is there any difference between these conditions? They're all sort of made up because we don't have any kind of specific marker that would say you have one or you have the other. Treatment is basically the same. It's supportive care, oftentimes in the pediatric intensive care unit because of the severity of the manifestations. IVIG and steroids and aspirin, and sometimes medicines used to combat the overactive immune system, combat those cytokines. That's what's used. And for most children, going to be just fine. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.